Hi, I'm Jim Glidewell. Many years ago, we videotaped an impromptu presentation that I gave to our lab managers. In that meeting, I spoke mainly about dental anatomy, breaking it down into common sense ideas. And while I talked, I illustrated the concept with simple sketches. That video has been instrumental in helping hundreds of our technicians understand dental anatomy, and I can tell you that it has been a huge success. I have always wanted to remake that video with graphics of much greater clarity and dimension. Also, I always knew there were some other topics that should have been covered and some that should have been covered in greater detail. Well, finally we did it. We've remade that video, and in it we will cover whole arch anatomy, anterior anatomy, and posterior anatomy. And I believe that by studying the information contained in this video course, you will be learning how to put all of the pieces of your dental technology knowledge to work. As a result, you will become more productive and will make better restorations. These concepts certainly proved their worth when I was at the bench. If you could look closely at the majority of the restorative work that we do here, you'd find that our cases are relatively easy, especially when compared to the complex build-up techniques of, say, Willie Geller or even Yamamoto. Those guys are trying to reproduce all sorts of anomalies in teeth, like silica fillings and decay, in order to make their teeth look more natural in the mouth. But we certainly don't need to do any of these tricky things here in this country, because when it comes to dentistry, most patients simply want to restore the function of their mouth with clean, white teeth. Most patients are unlikely to spend good money trying to match bad teeth. Now, I want to make it very clear that these are very basic concepts that we're covering here. However, it is these basic anatomical concepts that account for about 98% of the qualities our dentist customers are looking for in your restorations. The truth is that most technicians can learn to make great looking teeth, but how will they know if the restorations look great in the patient's mouth, or if they will even function properly? Of course, our dentists give us feedback all the time. But did you know that an experienced technician usually has some idea before shipping a finished case that it will meet the expectations of the dentist? That's because experienced technicians are the experts when it comes to tooth morphology, even more so than most dentists. And why is that? Well, because during a 4-year dental school program, the average dentist accumulates approximately 200 hours of dental lab time. That's equal to only about 5% of their total education. In comparison, a lab technician gets that in about 5 weeks at the bench. Keep in mind, the only reason dentists end up with such a small amount of dental lab experience in school is that there is so much to cram into 4 years, so much that it would boggle your mind. And once they finish school, dentists will rarely, if ever, have to make teeth again, and instead rely on dental technicians like you to make the teeth for them. You must realize that dentists are necessarily limited in the amount of dental morphology that they learn, and at the same time, you need to maintain your respect for the tremendous amount of knowledge they do have. And know this, even with all of their knowledge, dentists must still attend classes regularly in order to keep up with the new technology and new techniques. Therefore, it is not so surprising that the average dentist can never have the same mastery over tooth morphology as most skilled dental technicians. They just don't get the same hands-on dental lab experiences as we do. I will tell you that most dentists are the first to admit that. Take me, for example. I have personally made over 100,000 crowns. How many dentists do you think have that kind of experience? Very few, I would think. So what you need to understand here is that you, the dental technician, should be the expert in making teeth, not the dentist. The simple fact is that when a dentist rejects a restoration, the issue is going to be the morphology, not the shade. You can put an A2 central next to a D2 central, and if the morphology is correct, most often they will appear to match, and even a dentist won't notice. We know that dentists are experts at what they do, but they can't be expected to be experts in morphology. They need you to be the expert. You should know much more about morphology than they do, and you should be able to sit down and carve perfect teeth for them. There are a couple of very important whole arch concepts that we need to cover, and they deal specifically with curves found in the dental arch. These are the curve of Spee, which refers to an arc as seen from the side of the mouth, and the curve of Wilson, which refers to an arch from the front of the mouth. This is not rocket science, but it does give you a reference point to work from. We'll start with the curve of Wilson. Identification of this curve comes from dentist George H. Wilson of Cleveland, Ohio, who recognized that teeth in every human jaw are aligned in this curve. This alignment makes stable masticatory movements possible while helping to keep food in the chewing cycle. To understand how to create this curve on your restorations, I want you to think in terms of a face as seen from the front. There's a slight depression on the midline about 4 inches above the incisal edge of the upper centrals, between the eyebrows. This spot is called the glabella. Place one end of a 4-inch straight edge on the point just described. By swinging the straight edge mediolaterally, that is from side to side, you create an imaginary line, an arc really, with a 4-inch radius extending to either side of the dental arch. This is the curve of Wilson. And just what does this curve do for us? It helps us determine the alignment of each tooth in the arch. Looking only at the lower arch, we can see that on the left side, the curve of Wilson touches the tip of the buccal stamp cusp and then the lingual shearing cusp of the lower posterior tooth. Continuing, we can see that the curve crosses over to the right side of the arch, touching the lingual shearing cusp and then the buccal stamp cusp of the lower posterior tooth. As you can see in the lower arch, it is the lingual inclination of the posterior teeth that creates this concave arch by making the buccal cusp of each tooth higher than the corresponding lingual cusps. What I'm trying to get at here is that because of the way teeth sit in the mandibular bone, the linguals better be shorter than the buccals. In the upper arch, however, the buccal inclination of the molars and premolars places the palatal cusps lower than their corresponding buccal cusps. Notice that when a mediolateral curve is applied, it is the same shape as that of the lower arch. But in the maxillary arch, the curve is convex. What I want you to remember here is that on uppers, the buccal cusp better be shorter than the palatal cusp. You might find it interesting to note that we will also see a similar curve if we mark each occlusal contact and then connect the dots. Now I hope everyone can understand this because we frequently see inexperienced technicians making the lingual cusps on the lowers the same height as the buccal cusp. And why do they do that in the first place? Because the lingual cusp tips on the lowers aren't opposed by anything. An inexperienced technician often thinks of this occlusion as one flat plane, but that kind of thinking can lead to periodontal damage during lateral excursions of the mandible, because posterior teeth can withstand tremendous vertical forces but cannot endure continuous lateral forces. However, when the teeth are arranged so that they follow the curve of Wilson, during lateral excursions, the cuspids will help disclude the posteriors, preventing periodontal damage. Another whole arch concept that will help you understand the relationship of teeth and the dental arch is the curve of Spee. The curve of Spee was recognized by German embryologist Ferdinand Graf von Spee. When we talk about curve of Spee, again, I want you to think in terms of a face, in this case, a facial profile. Align one end of a 4-inch straight edge with the glabella. This is the same landmark we identified when creating the curve of Wilson, except this time we are seeing it from the side. If we swing the straight edge from the front to the back, that is anterior-posteriorly, the bottom edge creates an arc with a 4-inch radius. Limit the length of the arc so that it begins at the tip of the lower canine and follows the buccal cusp of the premolars and ends with the distal cusp of the last molar. This short arc that remains is the curve of Spee. So what does this curve do for us? Well, in combination with the curve of Wilson, curve of Spee is especially important when setting up dentures or large bridges, helping to establish occlusion when there is little or no existing dentition. When creating dentures, there are very few references to guide you as you reproduce both tissue and teeth. So in order to complete a full mouth restoration, you need to add these curves to your denture setup in order to establish bilateral balanced occlusion. That way, you can place the teeth correctly and stabilize the denture. To help you quickly establish these curves, denture tooth setting plates have been created. They are available as a standalone tool or as an accessory for most articulators. These plates approximate the size of an arch and take the guesswork out of setting teeth by giving you a 4-inch radius in each direction. When setting lower denture teeth with a setting plate, you cannot make the lingual cusp tips higher than the buccal cusp tips without creating a gap. It's that simple. The plate makes it easy to recognize setup mistakes that are easily fixed. Denture plates can also be used when creating fixed restorations with mini units. In these cases, you typically have to create the compensating curves yourself because there is a lack of remaining teeth to use as references. But by using denture setting plates, the curves are created for you and will save you a lot of time. Even if you are doing a partial denture or crown and bridge work with just a few units, you can speed up production by using a denture tooth setting plate. In these cases, you will likely be setting or building teeth that complete or idealize existing curves. You'll also find setting plates useful for checking your final work. So whether you're making a single unit or creating a full mouth restoration, you need to be aware of these whole arch concepts. That is the curve of Wilson and the curve of Spee. Next up, we're going to talk about anteriors. Now let's talk about the most prominent teeth, the anteriors. In this section, we'll cover basic anterior setups, translucency and shading, build-up techniques, surface anatomy, surface texturing, staining, glazing, and polishing. The first thing I'm going to do is give you my guidelines for a basic anterior setup. By adhering to these guidelines, you'll find that you won't need to get too fancy rotating centrals or overlapping centrals with laterals in order to make the teeth in your restorations look more natural. Now, in order to visualize these anterior concepts, I want to first establish two lines of reference. The first is the midline, an imaginary vertical line running between the upper centrals. The second is a horizontal axis, an imaginary line running at a right angle to the midline that approximates the position of the upper anterior incisal edges. So let's get started with a basic anterior setup. Now, I would admit that perfect teeth look perfect in the mouth. However, we don't have to build symmetry into a setup to make teeth look natural. I want you to know that right up front. If you look at really nice mouths, you'll see, for example, that laterals on opposite sides of the midline are each positioned a little bit different. They may appear perfectly symmetrical, but when you really study them, you'll see that each side of the mouth is not the same. A basic anterior setup includes these 4 criteria. Number 1, the teeth must be mesially inclined. Number 2, the teeth must have rising contacts. Number 3, open embrasures must exist between adjacent teeth. And number 4, the lengths of the anteriors will vary. We'll talk about mesial inclination first. By mesial inclination, we mean if this is the midline, then every anterior on this side of the face has to have the incisal edges inclined with the mesial position higher than the distal. For symmetry, the incisal edges of every anterior on the left side of the face should also be inclined mesially with the mesial incisal position higher than the distal incisal. So in other words, the mesials of the centrals are going to be shorter than the distals, and the mesials of the laterals are going to be shorter than the distals. Get a mirror and look inside your own mouth to see if your teeth are mesially inclined. If it's natural dentition, I'll bet they are mesially inclined. If you're wearing crowns, it will depend on the lab that made them. With denture setups, it is easy enough to rotate the teeth in order to give them mesial inclination. To make my point, if this is an upper right central and I want to give it mesial inclination by rotating it in this way, what happens to the distal and what happened to the mesial? As the mesial goes up, it gets shorter. As the distal goes down, it gets longer. How can it do anything but that? It has to obey the laws of physical science. If I turn something, all corners have to turn. On the other hand, if I want distal inclination, it's very simple to do. I lengthen the mesial and shorten the distal by rotating it this way. Now I have the appearance of a distally inclined tooth. If you are creating teeth using a build-up technique, the root is fixed and the crown cannot be rotated. And adjusting the incisal edge alone cannot achieve a mesial inclination that looks right. In fact, mesial and distal line angles will need to be created in order to give the appearance of natural tooth inclination. So what is a line angle? A line angle is where two surfaces intersect and create an angle giving the perception of either a curved or a straight edge. In anteriors, there are 6 possible line angles for each tooth. These include the labioincisal, mesiolabial, distolabial, lingual incisal, mesiolingual, and the distolingual. The most important line angles for creating mesial inclination are the distolabial, the mesiolabial, and the labioincisal. The labial surface that these 3 line angles share catches and reflects light, while the remaining surfaces are typically in shadow. By controlling the combination of light and shadow in these line angles, you can then restore natural tooth inclination. Next, look at the contacts in a natural anterior tooth setup. The mesials of the centrals touch each other at a point pretty low and fairly close to the incisal edge. The mesials of the laterals contact the distals of the centrals at a point that is somewhat higher, and the mesials of the cuspids contact the distals of the laterals even higher. Basically, these contact areas are going to take off and then go uphill in what we call a rising line of contacts. In other words, if you connect the points of the contact, you get a curved line that starts low at the midline and gets progressively higher distally. This is how the contacts should be in a basic anterior setup. From the canine on, the contacts continue to rise, and if you look at the posterior contacts only, it's the same general curvature we observed when we learned about the curve of Spee. Remember, in order for you to make restorations with a rising contact line, you must build mesial inclination into the teeth. You can't do it any other way and have it look natural. Now, if people looked at only 2 teeth in the mouth, you would want them to look at the upper centrals. What I'm saying here is that I want you to make the upper centrals the most prominent of all the teeth. To do that, we're going to establish tooth proportions based on an angles class 1 relationship, where the upper centrals overlap the lowers by an amount equal to the overjet. In other words, overbite equals overjet. If I establish a horizontal axis based on the length of the centrals, then the cuspids too will touch the horizontal axis. In other words, the centrals and the cuspids are about the same length. We're going to keep the laterals about 1 millimeter above this horizontal axis. Incidentally, laterals are the smallest teeth in the upper arch, and on average, they should be 67 to 70% the size of the centrals, both in width and in length. An exception to this is when you have crowding and spacing problems. In these cases, you want to make the laterals narrower so that the centrals appear as normal sized as possible. Narrow laterals are much less noticeable than narrow centrals, and this will help a crowded restoration look good. Just remember to make this central so that it comes down as far as the cuspid. Notice, by the way, the bicuspids are not going to come down that far. If anything, they're going to get shorter and shorter and shorter as you move distally. Why? Remember the curve of Spee. That's the curve of Spee kicking in. Now, I would go back and change everything I just said and everything I taught in the past and say, just make the centrals below this line. This is the hot setup. If you make the central a little longer than the cuspid, then this is going to look great in the mouth. I see this all the time. Just give yourself a central that's a little longer than the cuspid, and it looks great and very natural. Remember, if the centrals are too long, it is very easy to shorten them, but nothing looks worse than centrals that are too short. If you are creating a ponic, the natural tooth is gone, and there is always bone and tissue loss. That forces the final restoration to be longer than the adjacent teeth. In cases of extreme tissue loss, you will need to add pink ceramic material at the gingival. That way, the apparent length of the ponic will look natural and match the length of existing teeth. To design a ponic, first identify the long axis of the ponic and the crest of the cervical contour. The highest point of the crest should be slightly distal to the long axis of the ponic. This makes the visible portion of the ponic appear to be shorter and medially inclined. Some technicians make this mistake. They make the highest crest of the ponic's cervical contour so that it is mesial to the long axis. You might say that doesn't look too bad, but I'll guarantee you by the time they made that little error, they've already lengthened the mesial, and now you're dealing with a whole different tooth. The long axis now goes through here to about the center of the tooth and doesn't look too bad, but all of a sudden it appears to stand upright and will be very apparent next to adjacent teeth. So what I'm saying is, make sure the highest area of the cervical contour is always distal to the long axis of the ponic. The next step in establishing a basic anterior setup is to open the embrasures. So what's an embrasure and why is it important to know about them? Embrasures are the spaces between adjacent teeth that result from the natural contours of interproximal surfaces. Embrasures provide a spillway for food, helping to maintain good dental hygiene. Remember, a great-looking restoration needs great-looking tissue around it. So in order to make natural-looking teeth, you need to open up the embrasures. You can refer to an uncut master model for tissue information in order to determine the size of the embrasures. For example, you don't want to have a row of big black triangles up through here. Embrasures that are too big won't look right. On the other hand, you don't want the papilla squeezed during cementation because of embrasures that are too small. This will cause the tissue to recede, exposing the margins, compromising the aesthetics of your restoration. The only way to get healthy and natural-looking tissue is to keep the papilla stimulated with open embrasures, ensuring good blood circulation. You know when the embrasures are open correctly, the tissue just looks healthier and the restoration looks more natural. Now let's go over this idea that men and women have different teeth. This is all a misconception. There is no difference between the teeth of men and women, and there's nobody born that can tell just by looking in the mouth whether it's a man or a woman. They're lying if they say they can, because we know from jillions of studies there's just no way to look at an arch and tell whether it's a male or a female. For example, compare these two full arch models. The one on the right is mine. The model on the left is from a woman. Compared to my mouth, her arch is much wider and the teeth are much bigger. There was a time when I would have thought that because I was a bigger person and a male, my teeth would be bigger. But they're not. In fact, if all we looked at were teeth, I would have picked my mouth for the woman's mouth every day of the week. These misconceptions probably came about because in general, when compared to men, the features of women are more rounded and delicate. Also, dentists often give us the impression that a difference exists because in their instructions to the lab, they will request a gender-specific setup. So for example, if the dentist requests a nice feminine setup with a softer, daintier look, what he's really telling us is, give me teeth with mesial inclination that are narrow and rounded on the incisal and gingival. He's also asking you to give him larger embrasures and shorter laterals. On the other hand, if the dentist requests a masculine setup because the guy chews spark plugs for a living, what the dentist is actually telling you is too drastic of a change at this point in this patient's life would just look weird. Just make the teeth like they were before. That is, very broad with square incisal edges and little or no mesial inclination. So it's that simple. If a dentist wants masculine, make the teeth square and incline them only slightly to the mesial. And to enhance the perception of a female setup, you can increase the mesial inclination. There are some common mistakes out there that I see a lot. That is teeth with no mesial inclination, with all the context down at the incisal edge, lying in a straight line. This is what is called the silver dollar or picket fence setup. As you can see, the teeth are square to the midline. There are no embrasures. The laterals are too long, and the centrals and cuspids are not long enough. These are morphological issues, and many times They're the result of a dentist trying to please an uninformed patient who wants them straight and white. This setup method is a sure sign that someone is wearing caps. Now, if you make teeth like this, I'll guarantee you I'm going to know those are caps. They're real easy to spot, and every laboratory in town is real good at making these teeth look straight up and down with the contacts in a straight line and all anterior teeth the same length. As technicians, you don't want to get into the habit of making your cases like that. So, to get away from the silver dollar setup, all anterior teeth need to be inclined. That is, inclined mesially. How many times do we look at people and the first tip-off that they are wearing caps is his teeth are the same length? Centrals, laterals, and cuspids all the same length. If you just drop the incisal of that central down to here, keeping the distal incisal edge longer than the mesial, you'd be surprised. You'll think it looks pretty natural. In fact, I won't mind at all if you give me this central down to here, past the horizontal axis. What's the worst thing that the dentist can do when he gets this back? He might say, this guy looks like Bugs Bunny. Then what does he do? He grinds the distal portion of the incisal off, and by the way, when he does this, he unconsciously changes the perception of axial inclination so that this tooth appears to be more upright and square. If you need to do this in the laboratory, that is, shorten the incisal, don't ever shorten the tooth here without really shortening it here. In other words, shorten the entire incisal edge. That way you maintain your mesial inclination. What if your 6-unit upper anterior restoration looks just like a classic silver dollar setup? If a masculine setup is not requested, then you're obviously on the wrong track. So what are you going to do? First, identify the problem. You can see that these teeth have no mesial inclination. The contacts lie on a straight line. There are no embrasures and the teeth are all the same length. These problems are easy enough to fix. First, we know that the laterals need to be roughly 70% the size of the centrals. So we'll cut them back so they're about 1 millimeter shorter than the centrals. Next, reduce all the incisals at the mesial. By doing so, the apparent axis of the teeth will change. Notice how the contacts begin to rise from the horizontal axis as we move distally. If you draw a line through the contact areas, you will see that the line of contact is no longer straight, but rising. Now the teeth are also starting to look mesially inclined, but you are not finished yet. You'll still need to round the incisals at the distal, especially on the centrals. If any tooth is too short at the distal, you'll need to add more porcelain to lengthen it. At this point, you can open the embrasures and establish facial line angles that are mesially inclined as well. Now you've got the contacts up where they belong, don't you? You can see now that by changing the appearance of the anterior teeth in order to achieve mesial inclination, the contacts also change. Now I'm looking for teeth that have from 2 to 7 degrees mesial inclination from the midline. Notice that there is more inclination on the laterals than on the centrals and cuspids. If you give me this, I'm going to be very happy. Unlike a silver dollar setup, a perfect anterior setup has mesially inclined teeth of varying length, high contact areas, and open embrasures. And man, they look really good. It's terrible. A lot of the teeth we make appear to be solid white. That is, they have an extremely high degree of reflectivity. This is especially true of bridges. Our bridges are often completely opaque and monochromatic, and they are supposed to look like real teeth. Well, natural-looking teeth are not one solid opaque mass. That's because they're made up of different materials that are translucent. Now, I did say translucent, not transparent. A lot of people confuse these two terms, and they are definitely not the same. Transparent is completely clear. You can see right through it. Translucent is not clear. It lets light through, but diffuses it somewhat so that objects beyond it cannot be seen clearly. And it is translucency that we look for in teeth, not transparency, because real teeth are not clear. They're milky or cloudy in appearance. In fact, at their core, natural teeth have a pinkish pulp. The pulp is surrounded by a yellowish, more or less translucent dentin, and that's covered with a white translucent enamel. Just put a light behind your own teeth, and you'll see they are definitely not opaque. Light does shine through them, some more than others, depending on the thickness of the tooth. For example, notice the difference between the cuspids and the laterals. Also, light shines through some portions of a tooth more easily than others. For example, you'll notice that the incisal edges exhibit more translucency than the rest of the tooth. Centrals, laterals, and cuspids have different dimensions and shades that set them apart, and we should take some time to understand why they are different. Let's start off by looking at the tooth with the thickest enamel. That's the cuspid, also called the canine. It also has the longest root. This tooth is designed to cut off and bite off anything it can catch. It's a very, very strong tooth and is the workhorse of the mouth. The amount of dentin in this tooth is enormous when compared to the other anteriors, and as a result, canines are the most color saturated. Because it has the highest concentration of color, it's also the darkest tooth. Right next to the cuspid is the lateral, the smallest tooth in the upper arch. This is also the thinnest tooth in the upper arch, and it has very little color saturation and a somewhat translucent appearance. If you look at natural dentition, you'll see that because of its thickness, the cuspid is much darker than the lateral and can be darker by a couple of shades. This is how natural dentition looks. Most technicians do not apply this knowledge to their work and make these two teeth the same shade, when in fact they should be at least a full shade apart. An A1 lateral sitting next to an A3 cuspid probably sounds terrible to an inexperienced technician, but that's the real world because these teeth are not the same. Under ideal conditions, the central for these two teeth should be an A2. In other words, the lateral will be one shade lighter than the central, and the cuspid will be one shade darker than the central. If you want to create a natural look in your anterior restorations, vary the shades of the centrals, laterals, and cuspids. But keep in mind, after 40 or more years of having a natural look, some patients will want bright, white, translucent-looking teeth. They want what they see in young people's mouths and do not want to copy the mouths of their contemporaries. Most dentists expect you to vary the shade of the centrals, laterals, and canines because in school they are taught that the lab knows what to do. Dentists learn if it's, say, 6 anterior teeth, all they have to do is tell the lab it's an A2, and the lab will know the laterals are a little lighter than the centrals and that the centrals will be a little lighter than the cuspids. Obviously, a little knowledge goes a long way in picking the right shade for a restoration. And to that end, there are tools available that can help identify a shade. The most commonly used tool is the shade guide. Shade guides were originally designed by denture teeth companies in the late 1800s to make tooth selection easier for dentists and their patients. Those first-generation shade guides were designed for complete dentures, and color matching to natural teeth was not a priority. They were not designed to match human dentition, and some shades fell outside the range of natural tooth colors. They were made to provide choices from existing denture teeth and indicated only the available restorative materials. They were denture shade guides. Denture shade guides always worked well for full mouth restorations because when you make a full denture, you're putting a whole mouth in. There are no teeth around it, nothing to compare it to. You can pick just about any shade and it'll look okay because all the teeth will be the same shade range. Even with all of their shortcomings, everybody used these denture shade guides, even fixed ceramists. They used them because that's what was available. However, for fixed ceramists, it was not easy to reproduce the colors from denture shade guides because they were made in unrealistic thicknesses, using different procedures and materials that differ from those used to create porcelain restorations. Over the years, ceramic materials improved and it became possible for the technician to closely match the shades of natural dentition. As a result, shade guides changed too. One of the best, the Vita 3D Shade Guide system, represents a quantum leap in shade taking for the dentist. By separating value, hue, and chroma to more accurately identify shades that lie within the range of natural human dentition. The current popularity of teeth bleaching has also greatly influenced shade taking, with patients now requesting lighter shades from their dentist. Tooth makers have even added high-value bleaching shades to their shade guides to take advantage of this trend. For the most part, 90% of all teeth you're going to make are A2, D2, A3, D3, and some A1. You can run A4 or darker if you've got someone really old and they're just got to have, say, an A4. I understand that. In general, I'd be very suspicious of any B3 or C shades you get. These shades in particular are a warning sign that you've got a dentist who cannot take a shade. And how do I know that? Years ago, I pulled all the lab slips and did my own evaluation of shades. I wanted to know what shades had the highest percentage of remakes and adjustments. I also wanted to know what shades the dentist had originally requested for these remakes. Well, it turned out to be that B3 returns were just rampant. So on a hunch, I started substituting A3 porcelain in cases where B3 had been requested. We began getting very positive feedback from our dentists where they'd say things like, "I don't know what you did, but you hit that B3 right on the money." After all that, it was apparent to me that creating correct morphology prevents more returns than any other aspect of a dental restoration. Furthermore, I concluded that the highest amount of shade returns were the result of dentists who requested B3s or any of the C shades. B3s and C shades are okay when used for denture teeth, but are not appropriate when trying to match living natural dentition. Now I want to talk about porcelain buildup techniques. In order to do that, we need to talk about a property inherent in ceramics, that is shrinkage. The powdered porcelains used to build up crowns and bridges shrink by about 7.5% when they are fired. Therefore, if you overbuild your restorations by that amount, that is 7.5%, you will achieve the desired final contour once the firing is complete. However, dental lab technicians have a tendency to overbuild the contours even more than the 7.5%, and then must grind off the incisals until the teeth become the right length. By doing this, the amount of translucent porcelain around the incisal is reduced until eventually there is little or no incisal material remaining, and of course, little or no translucency. Ultimately, this will waste porcelain and the technician's time as well. This is also how you end up with a terrible looking monochromatic tooth. So to avoid losing translucency, make sure your two powder buildup is 7.5% larger than your visualized final tooth shape. This is nearly a 1 millimeter increase in length for a typical central. We know that in a two powder buildup, several cutbacks must be made in the dentin in order to make room for enamel porcelain. That's the first buildup. The first cutback